Record.
Okay, here we go. I think we are live. Yeah, so I'm always excited to do things like this. Uh, Obviously, shout out to Team Luke Hope for Minds. You guys' organization is just unbelievable. The amount of support that you guys give, the amount of resources that are out there through you guys, whether it be through stuff like this or all the resources for the family, for brothers and sisters, for education about brain injuries, from different routes to go to equipment you're able to use. It's changed just so many people's lives, and I am extremely grateful to be able to kind of be associated with you guys and be a part of your guys' mission. And I love doing stuff like this where anything that I could do really to help give parents and families and even other clinicians more confidence and more conviction behind the reasons why they're doing certain therapies and certain interventions, I'm always going to be on board. So I love doing this stuff. So I will be back as much as you guys want me to be back, and all you parents want to hear me yap on the way. But I've done a lot of these presentations with different support groups, especially here in Arizona, and what I found best isn't necessarily sitting here doing presentations to you guys with 40 different slides and me running through them. I think that is best to kind of more so have me open dialogue, go back and forth, whether you guys have any questions or different things that you want me to talk about. Where I'll more so be an open book, where again, I just want to put everything out there, and hopefully you guys are able to put some of the stuff I say into action, whether that be the actual clinical application of it or just feeling more confident in the path that you guys are on. So if you guys have any questions, I believe I could see the chat messages pop up. But we'll kind of go from there. But I'll kind of start out just with a general
You're
overview.
muted. Yeah,
I'm
no, I
muted.
can't back in your dad. If everyone could please just mute themselves.
I thought you
I
said
don't
I'm
know if
muted.
that was
I was like, I just talked that whole
intentional or
thing while
not.
muted.
I'll let you go continue, and then once you're done, I can start off by reading the questions that we had
Yeah.
previously.
So I have been doing this stuff for a handful of years now. I've always practiced out here in Arizona. I started practicing alongside, you guys probably don't know the name, but other people in the therapy world would know them. But his name's Dr. Trevor Berry, where he's kind of a world renowned functional neurologist. Where I'm originally from New Jersey, but moved out here to Arizona upon graduation and practiced alongside of him for close to 2 years or so. And he is just a worldwide lecturer when it comes to laser therapy and clinical applications behind the neuro rehab. So I was able to learn a whole lot from him. And early on into practice, when I first graduated, I was taking any case really that I could, as any new grad does. But I was able to actually have my first. I was working with a lot of like autism and ADHD at the time, but I got my first referral over for a brain injury, and I knew what I wanted to do. I had confidence in the treatment plan, but it was the first time where I was able to kind of do from start to finish the interventions that I wanted to do and really map out this child's journey. And after working with him and seeing some of the gains that he was able to make, outside of some of the quote unquote traditional world with PT, OT, speech, I knew that this was my passion. I knew that this is what I wanted to do, because there are just so many options out there in the brain injury world that may not follow that traditional model, but have a lot of research behind them and have been proved efficacious time and time again. Where the model that we work in, if you kind of take a step back, it's our job to figure out which areas of the nervous system are working well and which area of the systems or which areas of the nervous system aren't working well. And that could even include things like the actual brain damage, which a lot of our kids present with. We know that through the power of neuroplasticity, and for those of you guys who don't know what neuroplasticity is, it's essentially the way the brain's able to grow and change. So the same way that we're able to learn a new instrument or learn a new language, the brain has the same capacity to be able to rehabilitate itself, whether it be physical, whether it be cognitive, whether it be emotional, where everything that we're trying to do as a functional neurologist is to grow those new and efficient connections in the brain to promote that good neuroplasticity. Now, when we work with especially a lot of the younger kiddos, the brain from a physical growth standpoint, it has something called gray matter and white matter in the brain. Gray matter is a little bit deeper inside. It's a lot of those deep neuronal connections, and those grow until you're 5, 7 years old. Where white matter is more of the connections grow. Oh, there we go. Grow within into your 20s. So the younger a brain is, the more potential there is to rehab it because it's still physically growing. Where if I'm going to do neuro rehab on myself, my brain, from a physical standpoint, is done growing. I can still make new connections compared to a 2, 3-year-old where their brain can make new connections, but is also still physically growing. When you combine things that promote that positive neuroplasticity with working even a step back with things like stem cell and hyperbaric and laser, you're able to even put new neurons into those damaged areas, which the brain can then reconnect to form new formations. And it's impossible to give a prognosis to somebody that young because the brain is just the most magnificent organ, and there's so much possibilities that the brain can do. Where you even see some of these cases where, like, I was just looking at one case study the other day, and this girl, she was 13 years old and presented with like headaches and neck pain and a bunch of weird neurologic symptoms going on. They did an MRI and she didn't have a cerebellum. There was no cerebellum there. So she was, in theory, performing tasks that should be impossible to create. But through the power of neuroplasticity and the way the brain's able to work, you're able to do things that's just pretty magnificent. To take that the other way, there's kids that with very severe seizures, they have what's called a hemispherectomy, where they take a whole side of the brain out. It's a very scary procedure, but if you take the right side of your brain out, in theory, you should never be able to use the left side of your body or feel on the left side of your body again, where some of these people are still able to maintain some of those functions. So that just shows that the brain has the ability to reorganize itself and to grow, quote unquote, around some of those damaged areas. Where when you leave a hospital whether it be a newborn or as such a young age, and a neurologist looks at you and says, they're never going to walk, they're never going to talk, they're never going to smile. And I'm sure all of you guys know that dreaded and terrible conversation, but just about every kid that I've seen have blown past those expectations. Not because we're better or some of these alternative therapies are superior, but sometimes it takes an integrated and a combined based approach to be able to reach those outcomes. Where PT and OT, they may be great resources for you and they may be great therapies, but until you're able to start working more foundationally, that stuff can stack on top of each other to make things like physical therapy and occupational therapy that much more beneficial. So to sum that all up, it's my job, it's our job, um, to make the brain stronger. The stronger the brain is, the better the brain's integrating, the more possibilities there are. So, do I work with XYZ symptom? Of course I do. Do I target my treatment plan around improving symptom X? I take a step back and I know if I improve the brain, if I improve the cerebellum, that in turn will improve symptom X. So it's taking a little bit more of a holistic based approach to neurologic health. And the brain injury world is complex. There's no sugarcoating that, and I think all you guys know that. And that's why it takes an integrative based team to be able to come together and work synergistically with one another. Because at the end of the day, all therapies are going to compound on each other. And really, every therapy that you do within reason, I should say, and knowing and confident that it's the right fit for your child is going to help the other therapies you're doing as well. So when you do laser therapy or hyperbarics, that in turn is going to help improve the physical therapy you're doing, the speech therapy you're doing. So everything at the end of the day is going to work synergistic, and we just have to keep putting the different pieces of the puzzle together. And the more pieces we're able to put together, the more complete of a plan that we're able to put together. Yeah. Does anyone have any questions? That's kind of the paradigm we work in, I guess. Does anyone have any questions related to anything that I just talked about there?
I do. We did the HBOT with our son probably 2 years ago. I mean, it wasn't easy to get to and easy to do, but I definitely think that it made him more aware and was a very helpful therapy. Um, but as far as getting a soft chamber in the home, do you think that that's just pointless and we should try to make it back out to do the HBOT?
No, I mean, I know plenty of patients that have soft chambers within their homes. I'm not a hyperbaric expert, but what I do know is that consistency goes a long way. A hard chamber, in theory, is going to have more benefits with increased pressure, etc. But soft chambers 100% have their place. And if you have a soft chamber, I know is a big investment up front, but being able to consistently do it, where you're able to do your 40 dives, take a couple week break or a couple month break, whatever the prescription is, that's gonna that's gonna work in our favor. Because at the end of the day, we're in this for a long haul. This isn't a quick, you do 10 dives and all of a sudden you're better. Um, is going to be a consistency factor behind all of this. And if you have the means to be able to get a soft chamber in your home, I am definitely all about it, especially if they've responded to it positively in the past. You know that that's probably going to be a good therapy for them. And in this world, there's a million to one therapies in theory you can do. But what I always tell parents is if you see a child responding well to a specific therapy, in this case hyperbarics, that's probably going to be one that you're going to want to stay on top of, because we know that it has the potential to change your physiology. Where again, having a soft chamber may not be as beneficial as a hard chamber, but you're still going to get the physiologic benefits that hyperbarics has to offer.
Thank you.
Absolutely. Anyone have anything else?
Sorry, I was just going to suggest that I'll go ahead and ask one of the questions that was submitted prior.
Okay.
So the question is, my son is a 4-year-old drowning survivor. What are the reflex integration exercises to do at home and how often? We have a laser, stim pod, Resimax, vibe plate, and home chamber. I heard from my DMI therapist that reflex is supposed to integrate first. Another question is, what are your thoughts about Trexo and TheraSuit modality?
Okay. Let me start with the primitive reflexes. So primitive reflexes, for those of you guys who don't know, I'll just give a little bit of a background to them. Primitive reflexes are reflexes that develop while we're still in utero, and they essentially help us survive the first year of life. So they help with everything from the birthing process to rolling to crawling to breastfeeding, so on and so forth. So all of these reflexes, they live in the subcortical areas of the brain called the brain stem. So if this is your brain up here, below it is that brain stem. So think about it like my little pen here. All of the reflexes live in this area. So the brain essentially grows from the bottom up and integrates and inhibits itself from the top down. That first step of the bottom up growth of the brain are these primitive reflexes. So a lot of therapists, they always preach about primitive reflexes are a phenomenal starting point because they're the foundation of the growth of everything else. So when somebody doesn't have that many skills that they're able to do, you almost want to think about the brain regrowing as if it was a newborn, where you want them to be able to grasp onto things, you want them to be able to roll, you want them to be able to crawl, um, so on and so forth. But all of these originate from the actions that primitive reflexes do. So if you have primitive reflexes present, which I'll tell you 99% of children with brain injuries have them still retained, is not like that in itself is a brain injury by any means, but think about it as a speed bump in what neurodevelopment should be. So for those of you guys in here who have come and seen me, I like talking about reflexes as it's like knowing how to ride a bike but still having training wheels on the bike. So if you have the primitive reflexes lingering around, it's always going to be something that's holding you back from continuing to progress. Where primitive reflexes play a huge role in things like MNRI. I know they do a lot with reflexes, and they do a lot of passive stimulation with reflexes, and that's why a lot of kids do extremely well with reflexes because it's working so foundationally. Now, the other side to reflexes that not a lot of people talk about is as somebody continues to get stronger, the brain's job is also to come down and inhibit reflexes as well. So if somebody, say a 25-year-old has a concussion, a lot of times their reflexes are going to come back out, not necessarily because they have a developmental delay, but the brain can't come down and turn reflexes off. Same concept with a 75-year-old with Alzheimer's. They have a lot of their infantile reflexes because the brain can't regulate the brainstem well enough. So you see these reflexes come out more. Now, where that ties over in our world is reflexes, especially with the pediatric brain injury world, they have to be worked on from the bottom up. But doing your brain-based activation, that has a role on inhibiting reflexes as well, especially the reflexes in the top part of the brainstem called the midbrain, which is like your Moro reflex, your fight or flight reflex. That is almost completely controlled by your prefrontal cortex here. So if you've damaged your frontal lobe and prefrontal cortex, that's going to have a very hard time turning off that sympathetic system of the brain, which is related to the Moro reflex. So I'm not telling you to do one style of reflex or another, because at the end of the day, it's going to be important to do both. But making sure that your care plan is working on that bottom up, but don't forget about that top down inhibition of the reflexes. And that's something that we commonly do look past, or some people look past when coming up with a plan. Now, when you're doing home reflexes, it's important to be able to be under somebody's guidance, because doing a home reflex plan is going to be a lot different for a child with a brain injury that may have very limited physical skills or cognitive skills. Where if you YouTube primitive reflex integration exercises, you'll see all sorts of things where you'll think, there's no way my kid's going to be able to do that. If you work with a therapist that is trained, especially with limited physical capacities, they're able to show you and come up with different ways that you're able to passively activate the reflexes. So what I mean by passively is you doing the reflexes and doing the movements for the child. Where in a perfect world, they would do it more actively, but a lot of kids that we work with, we have to start doing it passive. And as they continue get stronger, we're able to tie in more of the active component into the care plan. So there's not one catch-all primitive reflex home plan. Is more so somebody that's trained being able to decipher which reflexes are present and come up with a plan targeted at the reflexes that you still have that have yet to be integrated, and showing you the movements and exercises to ultimately integrate those, because the best way to get rid of a reflex is by doing it. So a lot of the reflex exercises mimic the same way that they would integrate in a developing baby or a developing child. So I know the primitive reflexes was a part of it. What's the other part of that question?
The other part of the question is, what are your thoughts about Trexo and TheraSuit modalities?
So we have a handful of kids that have Trexo, and I think the technology is pretty amazing. And technology is going to continue to evolve. It is hard to even conceptualize what technology, especially from a rehab standpoint, is going to be like in 20 years. That's a whole separate topic that I love talking about. But Trexo, I think it's important. I think it's another tool. I don't think it should be the only therapy that somebody does, but there is a lot to getting a child upright. That in itself is extremely useful. But when you're able to put them into this device that brings them through a proper gait cycle, like that is just so cool. And I think it's extremely important. Is it 100% necessary? I don't know, because I know there's a lot of alternatives that you in theory could do as well. But if you have the ability to get your hands on a Trexo or be able to use the Trexo, whether it's at home or in a clinic, I definitely think is a valuable tool to have in your toolbox. But what I'll say is it's also extremely important to not forget about some more of the foundational stuff on top of that. Just because your kid's upright and walking with this guided walker, don't forget about how it's probably important to make sure that they still get on the ground, that they're going to have to try working on different crawling based stuff, because until they're able to master some more of the foundational stuff, it's going to be very hard for them to have an independent gait pattern, because there's so many things that tie into a proper gait pattern, from a reflex standpoint to a core stability standpoint to a proprioceptive standpoint to a vestibular standpoint. And the Trexo definitely helps with those movement patterns, but don't forget there's more to the picture than just doing Trexo therapy. TheraSuit, I have seen a lot of kids use them. I personally haven't used one or don't have them in my office, but I think it's another great guided feedback to help with some of that core stability and proprioceptive input, where if you're able to put a kid in an advantageous position, like with the spider cage and stuff like that, I think that's another great therapy too. But same concept applies with the Trexo. If you're doing that stuff, you have to remember there's other foundational things that you have to be doing. But as you're doing all of that foundational stuff, is going to make the Trexo and make the TheraSuit and make the spider cage that much more beneficial of a therapy. So that kind of goes back to what I was originally talking about with the integrative approach. So if you're doing reflex therapy, DMI, laser therapy, hyperbarics, and stacking on top of it Trexo, then that's awesome compared to just doing an isolated intervention. I know that's hard to do, but when working with very severe cases and tough cases, it's just important to have that integration with it.
Thank you. We do have a question in the chat. It says, what medication or therapy do you recommend to fix reflux?
So I'm not a prescriber. I'm not. Reflux can go many different ways. Um, Reflux can be a tricky thing to deal with. We've been seeing some success with some of our chiropractic based stuff working through with reflux. And you don't even have to be a or a functional neurologist, chiropractic neurologist to work through it. But there's certain moves that you could do with like the pyloric sphincter. So essentially, what happens is you have your mouth, you have your esophagus, which is like a long tube that goes into your stomach. There's a sphincter at the top of your stomach called the pyloric sphincter, which has to have proper regulation. So if that sphincter isn't working the best way that it can, you could have some of that regurgitation, which can result in some reflux with like that stomach acid and stuff like that coming up that esophagus. And a big thing that does work well with reflux is vagal nerve stimulation, because the vagus nerve is in charge essentially of modulating all the sphincter tone. So as the sphincter gets stronger, a lot of times reflux in turn decreases as well. And one way to do that is by vagal nerve stimulation. There's a couple other supplements that work on like acid-base balance within the stomach. Like there's one called Pepsidex, I believe, from Zymogen. We see a lot of people do well with reflux on that. A lot of applications that you could use with the laser as well. We use Erconia laser, and we're able to use a couple of different wavelengths like the purple, red, green, but we've been doing it a lot, starting at the top of the stomach, running up the chest, running into the neck, even putting the Resemax on certain places at the bottom of the neck and top of the stomach that help to activate those muscles and sphincters a little bit more, which we found to be quite helpful as well. Where there are some medications kids go on, honestly, I think is a hit and miss with it. But if you talk to your prescriber, if the reflux is really bad and alters your day-to-day activities, I think it's worthwhile giving some of the medications a shot. If not, there are a lot of alternative things that you're able to do in theory with supplements, with laser, with some soft tissue manipulation stuff, chiropractic, Resimax, things along those lines.
And then another question was, when activating the right brain, would you place the Optodrum app on the side of the left eye?
Okay. Okay. So I'll start just by talking about gross right brain stimulation. So when working through the hemispheristic model, there are a couple different trains of thoughts with it. The hemispheristic model is more so based around things with like developmental delay, like autism, ADHD, dyslexia, where right brain delays are going to be a little bit more with like your social impairment, your gross motor, your big picture understanding of things, compared to the left brain, which is more your like academic learning difficulties, fine motor. And I think the hemispheristic model is appropriate in things like autism and things like that. But when it comes to certain brain injuries, there's a time where you want to use the hemispheristic model, but there's times where you have to have full gross brain activation. So with this question, we'll talk more about right brain activation, where everything from a sensory input and motor output comes from a different area of the brain. Where if you have a localized lesion, whether it be like a one-sided stroke or like a lacunar infarct that just hits one area of the brain, then attacking it from a hemispheristic model can definitely be advantageous. So if we just run through the sensory inputs, you have vibration or touch on one side of the body, on the left side will go up to the right brain. Smell is actually the only one that doesn't cross over. There's your Jeopardy fun facts of the day. If you're ever on a trivia night, the only sense to not cross over in the brain is smell. So if I want to activate the right brain through smell, it goes through my right nostril. Sound in my left ear crosses over to my right brain. Now, with sound, is a little bit trickier because it goes around like 60-40 or so. So if I put sound in my left ear, 60% will go to my right brain, 40% will go to my left brain, give or take. Um, then you do things like um, vision, light. So light goes the corner of both eyes. So if I shine a light in the left corner, in the corner of my left eye, like that, that's going to cross over and go to my right side of the brain. And that's why I'm sure you've seen at some of the functional neurologist's office, you have the glasses that blink, is because it stays in one field to cross over to go to the other side. Now, when we go talk about things like eye movements, like with the optodrum, quick eye movements to the right, or we'll talk about the right brain. So quick eye movements to the left comes from the right brain. So if I'm looking at jump, 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 that's from the right brain. Slow to the right comes from the right brain as well. So when you're doing things like this question is about the optodrum, that's working through something called optokinetics. So if you put the optokinetics or optodrum going to the right, no matter where you put it, that's going to go through and activate the right brain. There's other neurology where any sort of optokinetics is going to be a right brain stimulation in general, but if you're looking at just the eye movement aspect of it, with optodrum, making the objects or the stripes go to the right will be a right brain stimulus because you get to track it to the right and then your eyes pop back. But I won't go too much into the neurology of it. But objects to the right, right brain, objects to the left, left brain, for an easy way to put it.
And I think you might have answered it, but I think this is a follow-up in relation to this particular topic. So the brain injury is on the left side, so she has right side weakness. Would the parent stimulate with the optodrum or light on the left?
Yeah, hey Nancy, give Liv a big squeeze for me. But
I
so
will.
if you're trying, but if you're trying to do left brain activation, it's the same concept. So, oh, my light just died. I got my phone. So you go into the right eye, and that crosses over to the left side of the brain. And then for the optodrum, if you have the objects going to the left, that activates the left side of the brain. Yeah.
So in her case, putting opto on the left, going towards the right, would force her eyes because her eyes turn into the left.
Let me see
So
if
her
I
right
have.
eye is very weak, remember?
Yes.
I'm so confused with it. That's why I'm asking this question because I'm like,
So
okay.
make sure you're talking about optodrum, not hemistim.
Yes.
Okay, because a lot of people mess them up. So with certain eye movement weaknesses, there's a couple ways really to go about it. Optokinetics is a good way to do it if they're able to activate those eye movements. Other good ways to do it is by rotation as well.
Okay.
So if I rotate to the right and you're able to look at somebody's eyes, is the same exact thing as doing leftward optokinetics with your optodrum. If I
Okay.
rotate to the left, that's the same thing as doing optodrum for the right brain. So we do a lot of rotation and stuff like that in our office because that is a passive way to activate eye movements. Because when you do optodrum, a lot of times it's hard for kids to even maintain their attention on there. Where if we're trying to bring, in theory, the left eye out, if they're able to fixate on a target, you can either hold up an object and have their eyes to the left while you rotate them, or you can rotate them to the right, because when you rotate to the right, the eyes go left and then shoot back to middle. So that is going to be a way to bring the eyes outwards and strengthen certain weak muscles.
Okay.
Man,
Yeah.
this is a lot of neurology. I didn't think I'd be
Yeah.
talking neuroscience tonight.
That was, I mean, her right eye has gotten better. It's not as weak as it was, and she follows more.
Okay.
But I want to make sure that I am actually doing it right first and foremost, and giving her everything she needs to actually get that eye.
The other way that you're able to activate eye movements that you can't forget about is just your basic VOR. So
Okay.
having somebody look at an object. So if you look at my eyes in here, we're getting real up close and personal. If I look right at the camera and I turn my head to the right, my eyes go to the left. If I turn my head left, my eyes go to the right. Now, if you were to cancel everything out of my face and just look at my eyes, it'd be like my eyes tracking an object back and forth. So by using the vestibular system, we're able to activate the eye movements passively, um, which in turn is going to help the active eye movements as well. So this, from a neurologic standpoint, is a lot similar to that.
Okay. Got it.
Yeah.
All right. Cool.
There may be one more person who has a question, but I think they're struggling to connect. So once I get them back, then we'll ask. But there's another question in the chat. It says, back to HBOT therapy. Are you familiar with normal baric oxygen therapy, and have you had any patients with improvement with it in addition to other therapies?
So
Sorry.
with HBOT, to be candid, I'm not an HBOT expert. I'm not gonna pretend to be. I know there's a lot of different protocols with it. I know I could probably think of 2 or 3 people off the top of my head with the normobaric, them doing very well with. I'm not one to break down the science of HBOT like I could break down different parts of the brain and eye movements. But I guess big picture wise, to answer this question, I have seen patients do well with normobaric. I don't know if it's necessarily better than people doing it other ways, whether it's with oxygen, without oxygen, going quote unquote deeper within their dives. Yeah, I know that's not the best way to answer that, but that's probably the best that I got when it comes to hyperbarics.
Hi, I have a question.
What's up?
Okay, we are actually currently in Arizona,
Oh,
because we're seeing Dr. P.
it's cold out
Um,
here, huh?
yeah. Well, we're from
It's usually
Chicago, so
not
it's
this
cold. It's cold over there too, so.
cold.
But I actually called your office to see about possibly seeing you while we're here, because we're gonna be here till February. But
Oh, cool.
I was they gave me your website, and I was kind of going, looking through it and whatnot, and I noticed that even Dr. P said you're really hands-on with the patients. So my question is, when I was going through like the website and seeing like different stories and whatnot, I noticed that a lot of the kids were like smaller, so you were able to manipulate their bodies and whatnot. And my daughter's 4'8", 100 pounds, and pretty like very little head control. It's almost like dead weight. So I like, are you able to work with someone that size and still, you know, obviously every kid is different, right? You don't know what the outcome is going to be, but
Right.
and be, somewhat successful?
Yeah, no, we work with kids of all sizes. We even work with, a couple of adults in wheelchairs that I think he's like 63, 64, where if we're able to, and with the size that you said, there's still potential that we're able to move somebody on a table or stuff like that. But we've had patients where we're able to just work with them in their stroller or their wheelchair, and there's a lot of stuff we can still do with that. Um, Even if it's just 1 or 2 transitions, usually that's enough for us. But a lot of the therapies that we do, we're able to kind of adapt to somebody's situation where, for example, if we're doing vagal nerve stimulation, a lot of times we have somebody laying on their back with the laser over their tummy, laser over their neck. We would just do that by staying in the chair and keeping them comfortable, and we're able to still hit the same exact areas, but keep it a little bit more comfortable for the child, and also make the transitions a little bit easier both on the parent and making it a little bit easier on us too, to be able to move somebody through all the different circuits that we have, where In our office, it's more so moving to different stations, I guess you could say. I'm sure other patients could describe it a little bit differently, but there's different therapies we do at different stations, and we're able to adapt those based off somebody that we're able to hold in one hand over my head, or maybe somebody that has to stay within a chair, or somebody that has to stay in one location for a longer period of time.
Okay. Is chiropractic part of the care that you give?
Yes, so chiropractic is another piece of the puzzle for us. We're not cracking everyone like a glow stick left and right all up and down their body necessarily, but we're able to do a lot of soft tissue, a lot of soft tissue based therapies, which helps out a lot, especially when it comes to hypertonicity, spasticity, head control, things like that, where we have a lot of different chiropractic techniques that we're able to use outside of cracking people. And any input that we're able to put in.
Okay, like, come on. Can I get help?
Ooh,
That wasn't me. So you
okay,
can go
sorry.
ahead.
So there's a lot of different chiropractic interventions you could do, whether it be on a tight pec or tight shoulder, or putting input into the spine. Spinal input is very important. There's all these tiny little muscles in between the spine, and if we're able to do chiropractic based interventions with them, that's all for the better. Then when you stack doing laser over the spine and doing vibrational therapies over the spine and doing electrical therapies over the spine, it all comes together, where chiropractic is great, but chiropractic is another tool for us. It's a very powerful tool, but it's one that fits into all the other therapies that we're doing.
Mm. Okay, yeah, I'm gonna be reaching out to you again while
Okay.
we're here.
Yeah, no, we're back in the office full time now, so you give Brittany a call up front, and she'll coordinate with you. We'll figure something out.
All right, thank you.
Absolutely. All right, what else we got here?
I think there's been someone who's tried to ask a question, but we were having some technical difficulties with the audio.
Okay.
So I think iPhone, that's the name that's shown. Do you have a question?
Was it me?
Yes.
Yeah, I was trying to like come in because it wasn't working when I tried to go. Like the first time I tried this live, it worked, but then it was like glitching. My phone wouldn't allow me to come in because I could see you guys, but I couldn't talk, or like I can't hear you. But I finally, like, I don't know, I messed with it and I figured it out.
Okay, good. Do you have a question for Dr. Bohr?
As far, I mean, I've heard stories like on people's background. I don't know, like, what if, um, like you say busy, right? Because I know a bunch of traumatic brain injuries have a side effect of having depression and just other things. What it happens if you keep yourself busy, but sometimes it's not enough to keep yourself busy, and depression she's trying to get to you. Because I keep myself busy. I'm a young lady, and I keep myself busy with like being active, doing chores, getting around the house. But sometimes I feel like it's not enough. What can I do then?
Yeah, I mean, there's a lot of things that tie into a lot of mental health issues from a physical standpoint. The two probably lowest hanging fruits are physical exercise and getting adequate physical exercise. And I think you mentioned that you get you're quite active, but the other
Yeah.
side to it, and something that's looked past all the time, even though it's kind of staring at us right in the face, is everything from a metabolic standpoint. So by that I mean the foods that we're eating, the different things that we're exposed to, different lab levels that we may have, where if you haven't had your labs checked in a year or whatever it may be, there's certain deficiencies that in theory that you can have, which completely impair your energy production, your neurotransmitter production, so on and so forth. And it could even be things like even the basic labs with like a anemia, with not getting enough blood flow to your brain, to improper glucose handling, where glucose is energy for our bodies. And if we're either hypoglycemic, so not enough blood sugar, or we tend the other side, which is more like insulin resistance, then our body is not going to be able to use glucose in the most proper way, which is going to rob your brain of energy to it. So if you're getting proper physical exercise, I recommend somebody that will be able to go through more of a metabolic overview with you, looking at lab levels, looking at diet, looking at possible supplements that you're able to do to give your brain and body the best energy that it can.
Yeah, cause like I was thinking of maybe the caffeine intake. I do fast from caffeine. Like I'm not drinking it every day. Here and there, I do drink my one cup of coffee, and that's about it, or half a cup of coffee, and that's it. On energy drinks as well, but not as back to back. I'll have them here and there, since
That's
I'll
the
be
thing. You want to say those energy drinks, they may give you energy in the short term, but they're just so loaded with a bunch of, whether it be sugar or stuff that's not good for your body, where long term that's going to rob your system of a lot of good things, where you get that quick jolt of it, but that's not the that's like putting a band-aid over it. You're not fixing the energy issues by drinking things like caffeine and Monster and Red Bull, stuff like
yeah.
that.
I'll lay off of that.
Yeah.
If you want
Yeah.
to send me a private message or a direct message with your contact information, I'll be happy to send you some additional resources as well that could be helpful.
Yeah, that would be helpful, because I'm also like, I'll drink up to coffee like once or half of it, due to like me being like, sometimes I'm tired from school, but I'm about to enter school again, so
Yeah. No, I think it's important to work with somebody that's able to take a more whole body approach, metabolic approach. I think that will help.
okay, thank you.
Yeah.
That's all the question I had today. Trying to figure this out, trying to have a question. That's
No,
about it.
yeah, no, hopefully that helps.
And I won't. I'm not afraid to reach out to people, so I can reach out to Miss.
Yeah, send
Yeah,
me a
I know
private
Ruby
chat
has some.
send me a
Perfect.
private chat and then I'll connect with you and get you some resources.
Work this, so I don't know if you can just send the little dots that way I can send you something.
Okay, will do.
Okay, thank you.
Absolutely. We do have a couple more questions. So could you please recommend any neurological facilities in Florida?
Where in Florida? Because I have a lot of recommendations there. It just depends where. So if you're handy right by your chat, if you could respond back, I'll get somebody for you.
Okay, and then while we wait, it says in Fort Myers.
The Fort Myers. So
Yeah.
Fort Myers, Dr. Bagnell's down in Miami. He has, I know, a lot of laser application. He has hyperbarics. He has worked with pediatric brain injuries prior. I believe Miami's probably the closest. We have another practitioner up in Tampa. We have another place in Orlando called Plasticity Brain Center. I know that's a pretty popular one. But if you're able to get down to the one in Miami, I think that's the closest with Fort Myers. He does some good work down there.
And how do you spell his last name?
Bagnell.
Okay.
And I believe his practice is Bagnell Brain Center. I'm gonna look up right now.
And I can type it in the chat once I
Yeah, so it's Bagnell, Bagnell Brain Center.
Okay. And then the other question was, what specialist can pick up therapy set for a child with TBI?
I'm not quite sure what that means. What specialist can pick up therapy set? So with TBI, I would say probably a trained physical therapist working with pediatrics should know a lot of things to do. Same with occupational therapy. I'm not quite sure what you mean by therapy set. Every therapist is going to have a little bit different of a approach that they use. So everyone's set, if that's what you mean, is going to be a little bit different. But the biggest thing that I'll say with finding a specialist is make sure that they have experience and confidence in working with brain injuries, because working with brain injuries are different than working with a child that's a little bit delayed. So make sure they have experience in this population.
I see one more question. Hopefully I don't butcher this, but there's some words that I'm not sure how to pronounce. It says our 4-year-old has went to Mind Eye Institute. She's done prism goggles, which help the eye turn. She still has some
Nystagmus, I got you.
Okay. But also when she's focusing on something, she tilts her head down towards her right side. Her eyes are more aligned, but sometimes see her left eye drift outwards.
So when it comes to ocular alignment and stuff like that, I've had a handful of patients that have been to Mind Eye, and they seem to do some pretty good stuff there with the prisms. There's usually more to it than just prisms. Like we see a lot of kids that have the strabismus surgeries, and they always end up coming back because it's not necessarily an issue. It's not always this case, but they'll go through and they'll shorten up a muscle or cut a muscle within the extraocular movements. But you have to remember all of those muscles are controlled by different areas in the brain. So as the brain and brainstem and the vestibular system especially improves, you should see improvements with eye movements as well, where nystagmus, essentially what nystagmus is an imbalance, and there's plenty of different types of nystagmus, but this is kind of an overview. There's the two parts of the vestibular system, and then within your brain stem, there's something called your vestibular nuclei. And what essentially it is an imbalance between those two sets of the vestibular system. So if you have that imbalance, it's going to cause the eyes to drift one way and then fixate back to where they should be. If is a true nystagmus that's just one way, it just beats one way, you improve that by working on the vestibular system. And that could be done by opposing the nystagmus. So if your eyes do this, we talked about here a half hour or so ago about those optokinetics, about the rotational therapy, where you're able to do the equal and opposite of what the nystagmus is. So if you have like a right beat nystagmus, which means eyes drift slow to the left and bounce back to the right, if you do rotations, for example, like to the left, that's going to cancel out and nullify the nystagmus because it's doing the equal but opposite of what the brain's doing. So nystagmus can be worked about in a bunch of different ways. With brain injuries, sometimes the nystagmus is a lot more tricky than that, where it's alternating, where it'll bounce one way, looking in one direction, the other way, it'll completely turn. And it's important to work on the brainstem for that. But with things like head tilts, that's all compensation for the vestibular system, where you have something called an ocular tilt reaction, where if I bend my head to the left, that causes the eyes to shift in the opposite direction. So when we see kids that have resting tilts within their head, that's their brain and body just compensating so they're able to see in a more appropriate way. So when you're doing your ocular therapy, it's important to have that neurologic component with it as well, especially working on like the vestibular system and the cerebellum and things like that. Hopefully that answers that question.
Thank you.
So, Yeah. So and even with the left eye drift outwards, like that could be too much tightness in theory with like your lateral rectus, which is the muscle that brings this eye out. But more so, what that is an inability of the medial rectus, which brings the eye in, to be able to hold integrity. So doing things like gaze stability with just looking at an object and literally just rotating back and forth, that will strengthen the, so in the example here, the left eye, that will strengthen the muscle that brings the eye in. And the more balance of the muscles from bringing the eye out to bringing the eye in, the better resting alignment that you'll have as well.
Two more questions. My son after TBI has CVI due to optical nerve damage. Is it treated?
So CVI could go a lot of different directions. Here with the optic nerve, there is some applications that you definitely can do for optic nerve. I have worked with a lot of kids with CVI, and a lot of them have improved. We've seen numbers completely change with CVI. When it comes to the optic nerve, it is a little bit different. It depends how much damage there is within there. There's a lot of different portions to the optic nerve, but what I will say is doing different visual stimulation, like with like the HemiStim app and using different colors depending on which optic nerve it is, and stacking that on top of things like laser therapy. I would say that would have a better chance of rehabbing a damaged optic nerve. Like you're able to do things with the laser where if you put it behind certain areas, you're able to actually go through and have the possibility of activating that optic nerve. There's even some lasers you're able to put over the eye. I'm not going to tell you to do that, but because I don't know which lasers you have, but with the lasers we have had people in the past be able to do some retinal based stuff with it, which has the potential to go through and activate the optic nerve. Where I'm not going to sit here and tell you that the optic nerve is going to be 100% healed, but there's a possibility of giving it more activation, which in theory could improve CVI.
Thank you. The last question that we have is, can you recommend any good physical therapists that are near Mesa, Arizona, that are used to working with kids with anoxic brain injury and have limited mobility?
Yes. So there is Dr. Erin Dinney. She does DMI. She is great. I know she definitely has experience with anoxic brain injury. Then there is, her name is Denise. She's at Amped Therapy, I believe, but she does spider cage stuff. It's like TheraSuit. I'll get her name now. So her name is Denise Berry, and her practice, where is it? Adaptive Movements is the name of her clinic. And she definitely has experience with anoxic brain injuries as well. And then the other one in there is Erin. Man, I called too many people by their first names. Lord. Give me 1 second here. So her practice is moving together therapy. And Erin, Dinnie, Dinnie, and she's great as well. So Denise is in Phoenix, and Erin is, I believe, up in Scottsdale, but I think she does in home stuff as well.
Okay, so I know it is 2 minutes past the hour, but we do have some more questions.
Yeah, I'll answer
If
a
you-
couple.
Okay.
That's fine.
What treatment do you recommend for myoclonic jerks? It happens when child is trying to stay asleep.
So myoclonic jerks, that could really be so many different things. Um, you want to first make sure that it's not seizure activity. If it is seizure activity, the treatment changes a little bit. But a lot of times myoclonic jerks comes from neurons being too close to threshold. So if the threshold is if this is the threshold, your resting cell should be here. Okay. When a cell gets unhealthy, it gets closer to this threshold. The closer it gets to the threshold, it takes minimal stimulus to come in and fire off, and you could have some of that unwanted movement. And that could happen with um, changes and like brain waves, which is certain things with sleep. There is a portion to transitioning brain waves, especially with sleep, where some people just get some little jerks. Like I know if we looked at all people in this room, I guarantee there'd be a couple people as they're falling asleep have a little bit of jerks. Um, and if that's the case, that's going to raise your eyebrow less compared to if it's happening constantly throughout the day. But at sleep, one thing that probably would be good is like a magnesium L-threonate product. Not only will that help with sleep, but that helps that resting membrane potential, and that may improve those jerks. If not, it takes a more thorough investigation and figuring out why they're there, what area they're coming from, etc.
And then the last question is, do you feel ABM therapy is beneficial for TBI?
Yeah, I'm not a. I've seen some ABM done. I'm not sure the specifics behind it, but I have a lot of patients that have done ABM. I know it works with certain movement patterns, and anything that you're able to do from um, a improving motor pattern standpoint is going to be beneficial, whether that's ABM, DMI. Um, I know there's a couple CME. I can't keep track of all these letters, but no, I mean I've seen a lot of kids do well with ABM. I'm not going to sit here and give you the science of it, but I think it's a beneficial therapy, and I think it's definitely worthwhile giving a shot to see how your child responds to it. And not every therapy is going to be for every single person, and you have to know when it's appropriate to keep going, but uh, when it's working for somebody, I always say stick with it.